Go.
Hi. So we've had a new admission, Mr. Jenkinson. He's a 70-year-old Caucasian man who was admitted on Section 2. There were concerns raised by the daughter around neglect, around cognitive decline, around sort of various other concerns about managing his finances, self-neglect. Yeah, so various concerns. He's on a Section 2. He was referred to memory clinic 3 years ago. He apparently had a scan but never turned up again at the memory clinic, so there was no formal diagnosis made. He was lost to follow-up. And so all the picture kind of points towards a dementia-like picture. And I wonder how he has been on the ward. Can we have the nurse to feedback, please?
Yeah, so when he initially came onto the ward, he was quite unsettled and he kept demanding for a cigarette. And he was also quite aggressive to both staff and patients. And so we had to put him on one-to-one observations. We then had to call the duty doctor because he kept requesting for a cigarette. So we got the duty doctor to prescribe the nicotine. And so since then, he has been better. He has been kind of more settled on the ward. We were unable to get any observations or any vital signs on him. But now that he's kind of settled, especially since he got the nicotine, we were able to see that his BP was quite high. But apart from that, he's slightly better, but is just still quite unsettled.
So is he complying with his antihypertensives?
No, not yet, I don't believe. So initially it was quite challenging. I think now that he is a bit better behaviour-wise, but I will double check with the nurses on the ward since.
Okay. So the blood pressure is high, and he's slightly more settled. Is he eating and drinking?
Initially, no, but I think he is improving as his behaviour is improving. He's also needing support with self-care on the ward as well.
Okay. And mobility, because there was concerns around falls, isn't it?
Yeah. So he is at high risk of falls, and his mobility around the ward has been poor, and it has been noted by staff as well.
Okay. So he's currently on one-to-one nursing. Is he on food and fluid chart? Can you put him on food and fluid chart, please?
Yes, we'll do. Yes.
And monitoring of the OBS as well continue. Lauren, could you tell me what has he been compliant on the antihypertensive, his medications?
Hi, yes. So I've discussed with his care home, and he's not been complying with any medication prior to admission.
You mean the carers? You mean the carers?
The carers, apologies. Yeah, discussed with the carers. And he's not been complying with his medication prior to admission. He's usually on several antihypertensives and also some analgesias and a statin as well, but he hasn't been taking any of these. So since his blood pressure is high, I think we could reintroduce some of his antihypertensives, but also bearing in mind he has a background history of chronic kidney disease. So we'd have to do this quite gradually. And the same goes for his analgesia as well. So we would want to generally avoid his NSAIDs and start with paracetamol.
Okay. All right. Thank you, Lauren. Can I have the medical feedback, please? Medical feedback?
Sorry.
So I decided to take a bit of collateral history from his daughter so that we can get a better picture of what's going on with him. And her name is Jane Martin. She was quite concerned about her father. She was able to give us a good detailed history of his decline in his mental state and health. She said over the last 2 years that she had been very concerned. And like you said earlier, he was seen in the memory clinic, but didn't follow up. So due to poor engagement, that fell through. His daughter was very concerned about his memory. She said it was very repetitive, asking the same questions over and over again. She was concerned about he was losing things around the home. He couldn't find his glasses, sometimes couldn't find his hearing aids. She was also concerned about cooking. She said that she sometimes would come to the house and find half-made things, that he would try to cook something and leave it halfway, and the whole house was unkept. She was concerned about the fact that he lost a lot of weight, so she could see that his clothes were becoming quite loose. So she also, because her father has lived there, it was a house that she grew up in, so she was able to speak to people around the area, and they were also concerned about his changing behavior. Obviously, over the last 2 years, he started offering money, and that was when I heard that, I was quite concerned about, risk of financial exploitation, the fact that he become very vulnerable. So he was offering money to shopkeepers. He would not wait to collect his correct change. If they would offer change after buying any product, he would say he didn't need the money. So she was also concerned. I asked her about any risk of wandering, if she was concerned if he was leaving the house. She said yes, that she was also concerned that 3 months ago he drove his car and got lost. It was actually the police that rang her, so she was quite concerned that that's quite risky. And she was so worried that he didn't get involved in an accident. So that was something that I think we have to discuss as a team.
Yeah. The wandering risk, the driving risk.
The wandering risk, the driving risk, the risk of financial exploitation is highlighted there as well. Yeah. And also not, decline in his activities of daily living, not able to look after his personal care. Like the nurses said, obviously that's reflected on the ward as well. Not able to do things that he used to do before. So
okay. So what's his current mental state? So current mental state?
Yeah. So Mr. Jenkinson is an elderly man. He appears to be slightly overweight, not very unkempt, dressed in dirty clothes with food particles that can be seen on her clothes. Appears slightly agitated, and anything that we ask, he finds it very challenging, and keep on reiterate that he was a retired professor, and it's sound in his mind. It's also very difficult for us to establish a rapport with him because he is very repetitive in his speech. He also seems to be confabulating and to fill in gaps in his memory. For example, if we ask what he has for breakfast in the morning, he said he has cereals, but when we confirmed with the nursing staff, he was actually having toast in the morning. He is also not orientated to time or place and has no insight to his condition.
Okay. All right. Thank you. That takes me to the concerns around falls and other sort of social issues. So if we have we got the physio and the OT online? So can I go to the physio first, please? Magesh, have you assessed him? Hello?
Hello. Yes, doctor. I just had initially a patient was not engaging with me, and I just gained a little information from the daughter Jane, and she told me that she had multiple falls in the last 6 months and trips and other things, and I was using a stick. But recently was like using the stick as a weapon to hit the carers when they came in, and, considering that probably is a Zimmer frame, a rollator frame could help. So I'm just after seeing him for two days now, once now the agitation being less, now I gave him a Zimmer frame, but since he is on one-to-one observation, I cautioned the staff that to be wary of that he could use this as a weapon, but still his gait is very unsteady. He can use the Zimmer frame. And another thing also about the footwear, he was not using a proper footwear. So I told the daughter to bring in a new set of footwear with a flat sole. So that will also prevent the fall risk. And these are the current assessment which I did with him.
Okay. Okay. Thank you, Magesh. Thank you. So OT report.
Yes, so it's still quite early days, and myself and Yasmin are still collecting some information for him. She tried to engage with him. When we mentioned like assessments that we might do on the ward, he was quite reluctant to engage. But he did have a conversation about what matters to him. So he discussed that he was a professor and he's used to having quite a set routine on the ward. And when Yasmin spoke to him, she noticed he wasn't quite attentive to her, like there was limited kind of eye contact. So it doesn't seem, there seems to still be a visual issue with him. So I came in and did a visual field test, and it seems like there's some issues with him, his eyesight on the left. So you need to kind of attend to him on the right when you speak to him. And going on from what Tracy reported, I looked over her notes and I just had a brief conversation with the daughter to fill in the gaps around what kind of activities of daily living in particular he's struggling with. And she said, like, he seems to be able to make a cup of tea, because she's observed cups of tea in the house, but it seems like there's quite a few cups of tea on this, like on the coffee table, and out of date food, lots of microwave meals left in the microwave. So kind of going forward, we'll just need to do a home visit with a joint home visit with Magesh, and to observe how the clutter might affect his mobility and risk of falls as well, and whether it's suitable for him to go home with a package of care, or whether we're looking at residential placement for him.
Okay, because the update I had was that maybe that they were struggling to engage him with carers, and because he didn't have the insight, he didn't think he needed a care package. So I think a home visit, maybe we could hold on for now, because I think we should have a professionals meeting to see if that is a viable option. And if that isn't a viable option, it might be a wasted trip for you, Susanna.
That's true. I think I need to kind of liaise with the nursing team and do a pool activity level to see. It seems like there's a sensory issue there going on as well with him inappropriately dressing. So I think I could gain a lot of information for that.
And could you take on the thing around sort of referral for a visual eye test? If you could liaise with the nurses, I think we should arrange for one. That seems to be a very important thing, and we might gain some functioning if his vision was looked into. Okay, thank you for now, and obviously we're going to meet again next week to discuss further. Annabelle, we've got psychologists around. Annabelle?
Yeah, I've been looking into Mr. Jenkinson's personal history. So obviously we know that he has a high level of academic achievement. He grew up without much of a family. He was generally a reclusive person, academic and very devoted to his work, and also a keen gardener. He obviously lost his wife about 10 years ago and took quite a matter-of-fact approach after that, and just tried to stick to his routine as a way of managing. His daughter doesn't know very much about his family history, so I says we don't have any information about any decline in his parents' functioning or cognitive abilities as they got older. Both his parents died in a road traffic accident, and then following that he lived with various relatives for a while. He left home early and then sort of, I suppose, dived into the world of academia and has stayed there ever since. I've been trying to engage with him to, I guess, get a bit of a sense of his mental health at the moment, to see if there's any element of that might be impacting on his functioning. And also some kind of cognitive assessment or screening would be really valuable to get a sense of where his thinking skills are at the moment and his cognitive abilities. I think given his high academic abilities, neuropsychology might be a viable option in terms of further assessment of his cognition. If there was any sort of, we'd expect him to do very well on any kind of screening tool, but we can think about the referral onto neuropsychology.
Okay, fabulous, fabulous. I mean, I've briefly met him. He doesn't seem across somebody who's depressed. So if you worry about kind of pseudo dementia or kind of a depressive picture, he doesn't fit into that picture. To me, he sounds more like somebody who's got maybe a mixed type dementia, because he's got all the vascular risk factors as well. But obviously we need the cognitive testing. So if we were to sort of collate all the information, I would say this is a man with cognitive and decline, with ADL decline. There is family concerns. There is engagement issues. So if we look at, and he's had a scan, so we need to bring together results of the scan that he had 3 years ago. It gives us a baseline and see what that shows, and whether we need to do another scan, whether he'd agree to another scan. And I'll wait for the so let's start with an ACE to see what we find on an ACE, and then if we need to for cognitive assessment, we'll move there. And I'll wait for the physio and OT assessment next week, and we'll speak to the daughter again. I have a feeling that we might need to go into the best interest. So we need to do a capacity assessment, financial capacity and capacity regarding care needs and place of abode. So Tracy, if you could do the assessments, the capacity assessments, please. And we need to find out from the daughter if there is, has anybody got an LPA? Does anybody know whether there is an LPA in place? Lasting power of attorney?
I don't think so. When I spoke to her daughter, it didn't appear that there was an LPA. I didn't ask specifically, but I can check and advise on the procedure of having an LPA.
Okay, fab. Okay. So if we do the capacity assessment, my reading from the history and what you guys have told me, it doesn't, and what my assessment with him has been, it doesn't seem like he would have capacity, but obviously we need to do a formal capacity assessment. And then we will arrange for a best interest meeting. We'll invite this daughter as well, and maybe the home treatment team consultant who was previously involved in sort of trying to engage with him at home, and the social worker as well who put the care package in. So get all the professionals involved, and we'll do if it comes to it, which seems like it very much would, to do a best interest meeting, and maybe the daughter could then apply for court of protection.
Yeah.
Because it seems that if we go through the risk, there is risk to self-neglect, not eating and drinking, wandering, falls. Is there any risk of DVTs mobilizing? Looks like he is.
I think he's mobilized. I don't think there's no risk of DVT.
And choking risks? Any choking? Is the nurse, has the nursing staff observed any choking risks?
No.
No. Okay. So there is all those risks to self, not engaging with the carers. There's risks to others. He's been using his stick as a weapon. He's driving, puts himself at risk, other people at risk. He's at risk of financial exploitation. So the risks are quite high in quite a few aspects, which, and almost kind of seems that going home might not be an option, but obviously we need to discuss it further. So we look at the scan. Let's do the ACE and capacity assessments, and let's kind of meet next week to see where we take it from there. Is there anything else anybody wants to add? Anything that we've missed out that we need to look into?
I was just going to add as well, depending on his capacity, I can do a blister pack assessment with him, just to see if that would help with his compliance in future when he's more towards discharge. Okay,
thank you, Lauren. That also reminds me about antihypertensives. Can one of the junior doctors liaise with the geriatrician to get advice on the antihypertensives?
Yes, we can.
Okay.
Yes, you can certainly call the consultants and seek his advice and make amendments.
Yeah.
Appropriately on the medication.
Yeah, and make sure we do repeat the bloods as well, because renal functions have previously been poor. Also, I know that on admission he refused ECG. He was too agitated. Can we attempt one today, please? He seems to be a bit more settled today. Because if he needs to start on cholinesterase inhibitor, we need to make sure we know the renal functions and if what his heart rate is.
Yes, we can facilitate that. We'll do that and document appropriately on the on view.
Yeah. Okay. Thank you. So if that's it, we can then sort of move on to the next patient. If nobody's got anything else to add, is that it? Okay. Thank you.